Hello everyone. Before I start presenting, I will introduce myself as a host that will guide you based on three case studies about health crisis. I, Nurella Maisara, will explain it to you about this crisis from the beginning until the end. Hello and welcome everyone. Today we will be discussing three major health crises that have had a profound impact on global public health, which is the H1N1 influenza pandemic or in 2009, the Ebola virus outbreak from 2014 to 2016, and the Nipah virus outbreak in Kerala, India in 2018. This outbreak, while differing in their scale, transmission dynamic, and geographical spread, all highlight critical lessons about the importance of the preparedness, timely response, and effective communication in managing health emergencies. Each outbreak provides unique insights into the dynamic of disease transmission, public health response, and effort recovery. By exploring these events, we can draw and significant lessons to improve preparedness for the future health crisis.
Okay, everyone, let's begin with the H1N1 influenza pandemic, which emerged in 2009. This outbreak was caused by a novel strain of the influenza A virus, commonly known as swine flu, which originated from pigs and spread rapidly among humans. The H1N1 virus had an unusual ability to infect younger populations, including children and young adults, in contrast to seasonal flu, which predominantly affects older adults. Within weeks of its discovery, the virus spread to over 200 countries, infecting millions and causing over 200,000 deaths worldwide. Before the pandemic, the world had a moderate level of preparedness for influenza outbreaks, with surveillance systems in place to detect new strains of the flu virus. However, the image of H1N1 in Mexico and its rapid global spread caught many countries off guard. Vaccination programs were not yet ready for this specific strain, though there were existing frameworks for the production of seasonal flu vaccines. Next, the response to the H1N1 pandemic was characterized by a combination of containment measures, public health messaging, and rapid vaccine development. Countries implemented travel advisories, social distancing measures, and campaigns to promote hygiene. Laboratories around the world quickly collaborated to develop a vaccine, which became available within months, though it lagged behind the initial wave of the outbreak. Public health organizations like the WHO declared a global pandemic and worked closely with governments to distribute antiviral medications and vaccines. Fortunately, by 2009, the World Health Organization (WHO) and national health agencies had established systems to monitor influenza outbreaks, which facilitated early detection. Vaccines were quickly developed, and antiviral drugs like Tamiflu play a crucial role in treatment. After the pandemic subsided, effort focused on evaluating the response. Investments were made to strengthen global surveillance systems and improve the speed of vaccine production. The pandemic exposed gaps in pandemic preparedness, particularly in terms of equitable vaccine distribution and communication strategies to combat misinformation. However, public anxiety was widespread, fueled by the fear of a global pandemic akin to the 1918 Spanish flu. Mass vaccination campaigns, hygiene awareness programs, and social distancing measures helped mitigate the spread. The H1N1 pandemic exposed gaps in healthcare systems worldwide, such as the needs of equitable vaccine distribution. Despite its lower fatality rate compared to the other pandemics, the sheer scale of the outbreak underscored the interconnectedness of the modern world and the need for pandemic preparedness plans. Next, I will presenting to you a video how influenza infection can spread between humans. Now, let's turn to the Ebola virus outbreak, which occurred between 2014 and 2016 in West Africa. This outbreak, caused by the Ebola virus, was one of the most devastating in recent history. It primarily affected Guinea, Liberia, and Sierra Leone, resulting in over 28,000 cases and more than 11,000 deaths. Ebola is a zoonotic
disease, believed to originate from fruit bats, is spread through direct contact with bodily fluids of infected individuals, including blood, vomit, and sweat. Unlike H1N1, the spread of Ebola was limited geographically, but the case fatality rate was alarmingly high, ranging from 50% to 90%. The crisis overwhelmed healthcare system in the affected regions, many of which lacked sufficient medical staff, isolation units, or even basic hygiene supplies. Early response efforts were delayed due to limited infrastructure and initial denial from local government. Community mistrust of healthcare workers further hampered containment efforts. During pre-crisis, the affected countries had weak healthcare infrastructure and limited disease surveillance systems, leaving them ill-equipped to handle an outbreak of this scale. Although Ebola outbreaks had occurred before, they were localized and contained quickly. The lack of preparedness in this nation, compounded by inadequate healthcare funding and training, set the stage for this crisis to escalate. The response involved a communication of local, national, and international efforts. Quarantine measures, contact tracing, and treatment of infected individuals were prioritized, but the response was initially slow due to delays in recognizing the outbreak scale. Healthcare workers faced significant challenges, including insufficient personal protective equipment, which is PPE, high infection rates, and overwhelming patient loads. International organizations like the WHO, CDC, and Medicine Sans Frontiers, which is MSF, play critical roles in coordinating response efforts. Experimental vaccine and treatments, such as the RVSV Zebov vaccine, were deployed during the later stages of the outbreak. During recovery, the focus was on rebuilding healthcare system in the affected regions, training healthcare workers, and strengthening global emergency response mechanisms. The outbreak underscored the need for international solidarity and faster mobilization of resources during health emergencies. Efforts were also made to improve community engagement and trust in health intervention, which had been significant barriers during the outbreak. In the aftermath, significant investments were made to strengthen health system in West Africa. The outbreak served as a wake-up call to the global health community about the devastating potential of emerging infectious disease, particularly in regions with fragile health infrastructure. The outbreak also emphasized the need for better training for healthcare workers and the need to fight stigma, as Ebola was highly feared and often misunderstood by the public. In the next slide, I'm presenting to you a video about what is Ebola in West Africa. The final case study is the Nipah virus outbreak of 2018 in Kerala, India. Nipah virus is a zoonotic pathogen transmitted from fruit bats to humans, often through contaminated fruits or direct contact with infected animals. The outbreak in Kerala was relatively small, with fewer than 20 confirmed cases, but it had a high fatality rate of over 80%, making it particularly concerning. During pre-crisis, Kerala had a relatively strong healthcare system compared to other Indian states, but it was not specifically prepared for a Nipah virus outbreak. The state lacked prior experience with this zoonotic disease, which is transmitted from fruit bats to humans, often through contaminated fruit that had been consumed by infected individuals. Human-to-human transmission occur among close contacts, including family members and healthcare workers. Limited awareness about the disease among healthcare workers and the public pose a challenges due to this outbreak of this crisis. Kerala's strong healthcare system played a crucial role in containing the outbreak. Rapid identification of the disease, isolation of infected individuals, and contact tracing were implemented effectively. Additionally, public health messaging about avoiding potentially contaminated foods and following hygiene practices helped curb the spread. During crisis response, the outbreak was managed effectively due to Kerala's swift response. Once the disease was identified, strict quarantine measures were implemented and extensive contact tracing was carried out to isolate potential cases. Public health authorities work tirelessly to educate the public about avoiding contact with bats and contaminated food. The government mobilized its healthcare workforce and coordinated with national and international experts to limit the spread of the virus. The outbreak was contained within a few months, with no further spread beyond the initial cluster. After the outbreak, Kerala strengthened its disease surveillance systems and implemented training programs for healthcare workers to handle zoonotic disease. Efforts were made to raise public awareness about the importance of hygiene and safe work practices. The Nipah outbreak demonstrated the importance of local governance, rapid decision making, and public cooperation in managing health crises. Despite Kerala's effective response, the Nipah outbreak highlighted the ongoing threat of zoonotic disease. It underscored the need for enhanced surveillance of wildlife disease, better diagnostic facilities, and training for healthcare workers to manage such emerging infections. I will show you how Nipah virus can be spread and how to prevent it from you to consume it. When we examine these three case studies together, several things emerge. First, all three diseases were zoonotic in origin, highlighting the importance of monitoring interactions between humans and animals. Second, each outbreak exposed weaknesses in healthcare systems, whether due to the sheer scale of cases in H1N1, underdeveloped infrastructure in the Ebola outbreak, or the sudden emergence of a rare pathogen like Nipah. Third, effective communication was a critical component in managing public fear and ensuring compliance with health measures. However, the differences are equally instructive. H1N1 was a global pandemic with a lower fatality rate but widespread societal disruption. In contrast, Ebola was geographically confined but far deadly, requiring intensive international intervention. Nipah, while localized, highlighted the value of a robust healthcare system and swift containment measures in preventing widespread transmission. Based on these three case studies, we can make several key recommendations for future outbreaks. For the first one, strengthen global surveillance systems. Early detection and rapid identification of new pathogens are crucial. Global networks, such as the Global Health Security Agenda, need to be further developed to detect and respond to new disease early. Investing in global and local disease monitoring systems is essential for detecting emerging pathogens before they escalate into pandemics. Technologies like genomic sequencing and real-time data sharing can play a crucial role in this effort. Second, build resilient healthcare systems. Government must prioritize healthcare infrastructure, including isolation facilities, diagnostic tools, and trained personnel, particularly in high-risk regions. Third, public health communication. Clear, transparent communication is essential in all stages of an outbreak. Educating the public and combating misinformation can play a significant role in controlling the spread of disease. For the last one, zoonotic disease preparedness. As many future outbreaks are likely to be zoonotic, it is essential to improve surveillance and response mechanisms for disease that can jump from animals to humans. In conclusion, the H1N1, Ebola, and Nipah virus outbreaks have taught us an significant lessons about the importance of preparedness, infrastructure, and international cooperation in managing health crises. While each outbreak presented unique challenges, and the common thread remains the need for a swift, coordinated response and a resilient healthcare system. By learning from these past experiences and strengthening our global health security framework, we can ensure a better response to the next public health emergency, no matter where it originates.